everything because she had just started out. So we left the tubes on so we could start treatment. So what we decided was we wanted to correct the angulation of the canines. So the canines were essentially lying on top of the centrals as well as the laterals. So what we decided was to not bond the upper arch, remove the wisdom teeth, try to correct the canine angulation first, and then go in for upper arch bonding later. And the lower arch, we removed the aids and decided to start aligning with low torque brackets again. So here it's important to consider one, the crown of the canine. It is also important to consider the root apex of the canine. So if your canine lies on the mesial half of the lateral, there's a 64% chance that it would come out safely, whereas there's a 91% chance if it lies on the distal end. But this is one of the criteria. According to the new guidelines for the assessment of maxillary canines, it's not just the crowns, but we also have to take into account the root angulations as well. So in terms of the root angulations, we have to consider whether the canine root lies in the space between the lateral and the first premolar. If so, it lies in the green zone. If it lies on top of the first premolar, it lies in the yellow zone. If it lies on top of the second premolar, it comes into the red zone. So again, these are criteria which make it safer or not safer for bringing out a canine into occlusion. So when we tried to check, we found out that the canine on the left side was lying at the border of the green and the yellow zone, whereas the one on the right side was lying almost in the yellow zone. So for us to be able to bring this into occlusion, we want to first try to bring these in towards the green zone, then make an attempt to see if we can bring these into occlusion. So this was the patient's CBCT. So we noticed that the patient had some exposure of the root. So we decided to do very pinpoint exposures on the canines and just try to correct the angulation first. So this was the patient's pre-treatment CEF. So you can see this here. So we decided to use low torque brackets, remove all the aids, and then try to correct the angulation of the canines. So you can see that we removed all the aids. The next step was to place 2 screws between the 5 and the 6 and just do bonded exposure on the canines and try to correct the angulation. So these are the screws in position. So because I wanted to use very less forces, so whenever I like to use less forces, I would normally go in for a power thread over a power chain. So it gives you very light continuous force compared to a power chain. So we just wanted to correct the angulation and see if we can move the canines, slide them on top of the roots of the lateral incisors. So 6 months into treatment, now you can start to see the canine root on the right side is almost in the green zone. This is still over there. So we just decided to continue this for some more time. So around 12 months into treatment, we were able to place heavy auxiliary wires as well as heavy base wires and a very light auxiliary wire to bring the canines, because now these were on the distal aspect of the laterals. 16 months into treatment, we were able to engage the canines directly. So we inverted the brackets just to get some more torque expression. 20 months, when the canines came down, we noticed a slight anterior open bite. So we placed drop-in hooks so that we could settle the occlusion on the anteriors. And we debonded the patient at about 25 months and we scanned the patient for aligners. So we basically used maybe 3 sets of aligners to correct the torque on the canines. And this is the patient's progress from the beginning to the end. This is her smile line, and this is her soft tissue profile before and after. This is the arch form, upper, lower, post-treatment X-ray. So you can see very healthy bone around the canines on both sides. And this is the post-treatment CEF, before and after. So in terms of finishing, we need to have proper detailing, well-settled occlusion, try to check for contacts on the canines before we finish treatment, and any offsets if required on the canines, usually to get a proper settled occlusion and finish. So some factors to consider in managing class 3s: We are doing this to essentially improve the quality of life of these patients, because a lot of these patients, I keep on mentioning the fact that camouflage is an option, but the treatment of choice should always be orthognathic surgery for a lot of these severe patients. Expansion is favorable because usually in a lot of these patients they have a low lying tongue posture. So when we expand, you can get the tongue to go to a higher resting position, which again adds to the stability. And in terms of retention, it's always better to use an acrylic retainer rather than use a clear retainer, because it doesn't give you the amount of strength required to overcome any kind of forces leading to relapse. So again, I do make mistakes, I'm sure all of us do. So it's very important to learn from each other's mistakes and try to improve, because at the end of the day, it's very important to provide our patients with the best kind of treatment. So with that, I'd like to thank you for your attention, and thank you so much.
Thanks a lot for your very beautiful presentation.